Excellent. So Ed, do you want me to drive the presentation? The
Please, if you
slides that I
can.
have?
Yeah.
Absolutely. All right, let me share here and find the right one. There it is. All right. Well, good afternoon, everyone. As Ed said, I'll do the appropriate introduction part here. I'm Mike Graypatch. I'm the President and Chief Executive Officer for the CareFirst Community Health Plan in Maryland. So what that actually means is that I run the Medicaid and Medicare businesses for CareFirst Blue Cross Blue Shield. We are a Blue Cross Blue Shield in Maryland, DC, and northern part of Virginia. We have a Medicaid plan in Maryland. We did have one in DC. Most recently, that's wrapping up. And then we have Medicare Advantage businesses also in Maryland. So pretty comprehensive set of work for us. As Ed was alluding to, I have a lot of history in healthcare, previously with Centene, Highmark, United Health Group, and Coventry Healthcare. A lot of that actually on the technology side. So I started off my time with a finance degree, and then it was the mid-90s, so I went into technology, then got into healthcare technology, and kind of progressed along that for a while, and then got the opportunity to move out of the technology side into implementations and then into running business lines. So kind of made the leap out of it. And in some ways I can say I don't miss having to do the technology side because it's a tough world where it's always infinite demand and limited supply. And you're always trying to answer all the reasons why something can't get done due to capacity or other reasons. So now I enjoy being on the other side, just asking why isn't that done now? So it's a lot more fun. So a lot of experience in Medicaid and Medicare, ACA, commercial business, kind of all phases of healthcare. And happy to talk about more of that as we have questions, but I'll kind of keep things moving. So a little bit about CareFirst. The area that I have, we have about 110,000 members in Medicaid and Medicare. Collaborating with over 7,000 providers across Maryland. And we are very invested in our community. As a not-for-profit health plan, we are focused very much on our mission. Of course, we need to focus on our financial responsibilities to make sure we have the money to deliver our mission, but we are committed to health equity. We are committed to having an impact in our community. We are committed to making sure that healthcare is delivered well and that the members we have their needs met, especially our lower income population with Medicaid and those who have complex needs in Medicare. So as I was thinking about this, and Ed and I talked a bit about kind of, what could I bring to the conversation? So as a former technologist, having moved into the business side, I can share a little bit about what technology means for us and how it works in some ways. So scale drives our business. When you think about the health insurance business, we'll start on the expense side. We have a large investment to serve one person. So if we have one member, we have to have all the infrastructure for compliance, for claims, for care management, for medical management, for all the things that have to get done. We have to have a provider network. But if we add on another 50,000 members, the incremental investment in people and technology capabilities isn't really much more. It's a very low variable cost investment, but a very heavy fixed cost investment. So much for us is a question of scale, getting more members in, growing that business. Every incremental member brings us a lot of revenue, but very little incremental cost. Of course, we have the cost of their healthcare, which is a good portion of that, but the incremental administrative cost is very low. And so the technology piece is what drives that scale for us and enables us to provide service to a broad set of membership across a diverse population in a most cost-effective way and help them meet their healthcare needs. Information is key to us. It drives everything we do. Everything is data-driven, especially for our Medicaid and Medicare businesses. The state and CMS are always asking us a lot of questions about our performance, and they publish that in a public forum about our quality, about our effectiveness, in some cases about our financial performance for Medicaid. So we are always being evaluated and assessed. And so data information are critical because we have to maintain an absolute compliance at all times with our business model. We look at cost of care. Again, information helps. We are always trying to find ways to gather more information from providers. So a lot of data exchanges and data interchanges back and forth with providers to get information from their electronic health records, to get information from them in terms of claims, so all the EDI transactions that come along with that. For us to share eligibility. It's a constant set of data going back and forth because while we fund the healthcare, the providers deliver the healthcare. And so there's a constant need to make sure that everyone's communicating almost in real time every day to make sure we're having the best impact we can on that membership group. So thinking about technology for us, one of the things to think about is that we have kind of a fixed revenue per person in our model. So the state or CMS or an employer group will tell us, this is what we'll pay you per member per month. And that's kind of the general model for revenue. And then we have to figure out how to pay for everything within that kind of construct. So we know that change is constant, but we have to be very judicious about how we're thinking about that revenue structure and how we bring it together. First and foremost for us, we have a lot of legacy technology. We have a lot of technology we implement and then we have it for quite some time because the cost of that change is dramatic. But also maintaining it is pretty dramatic. We have security, we have support, we have changes that may happen to other platforms that have adverse impacts on us and need updates and changes and modifications and testing. And it's a pretty dramatic set of work that we're constantly talking about in terms of our investment. So we never get to, quite honestly, I talk probably more about the maintenance and support and is the platform up than I get to talk about some of the fun things that we could do in terms of AI and other changes that might advance our business. A lot of the time is spent making sure that things are running and working effectively. Upgrades and changes, our vendor solutions are always changing. And that's probably something to mention. When I started in the industry, we had a lot of custom tech. Custom platforms for the web, custom platforms for claims processing, custom platforms for a lot of pieces. I've seen the industry really evolve now to pretty much platforms and bringing together those capabilities and a little bit of integration, but much more, finding the vendor who has the solution because the cost of maintaining that is heavy. To maintain a claims platform and continue the support and the regulatory requirements and do that across multiple states. Even for an organization our size of $12 billion of revenue and over 7,000 employees, that gets expensive, and it gets expensive to keep up. So we're always looking for, is there a way we can spread that cost across multiple insurance companies? And so we do that with partners like a Health Edge or a TriZetto, with Facets or other solutions that multiple insurance companies are using, customizing where they need to, but the base platform is supported by a vendor and infrastructure. And that's a way for us to spread massive cost. Also, when you look at the industry and you say, well, you have United Health Group and you have organizations like that are massive, that have their own technology organizations with somebody like Optum. We as a smaller player in the industry with our membership size, we need to figure out ways we can compete and be effective in that type of market. Platforms and investor and vendor partners create that kind of capability for us. We can spread that massive fixed cost of a platform and investment across more membership than we have and gain scale to compete with the large for-profit national players. When we're looking at technology decisions as well, for us, these always take longer than we think and give us less than we expected. Some of that isn't the technology's fault. Some of that is people have to learn. And they have to learn how the new technology works. They have to learn how it works well. They have to think about, how do we change what we do to make the technology maximize and gain the efficiencies of scale, efficiencies of operational impact, ways to make our business more effective and quicker. We don't always build that in as we're thinking through our problems. We expect we'll implement a platform and magic will happen and things will go very quickly. And we plan heavily for the IT resources, the testing resources, the implementation to turn it on. And we don't always do a good job of thinking about the operational change, the communication change, the what does this mean to the people who have to take over this platform. And that's where I see a lot of these types of things probably struggle a little bit, is where we run into the challenges of people absorbing and understanding and having to make a change. But people just don't absorb that in a day, and they have, time is what they need to learn and develop and get great scale out of it. Let me pause there for any questions so far.
Mike, I have like 5 I've already built on, but keep on going. We'll wait till you're done, and then we'll all hammer you with questions.
Sounds great, Ed. Thank you. So for me, one of the things I didn't realize before I came the CEO for the business is I spend a lot of time with my finance team, quite honestly, and then I get to talk to everybody else. And so much of it has to do with risk, reward, managing cost, making sure the finances work so that the business and the functions can be supported. So when we're talking about changes and we're talking about new technology, it's starting with the risk side. Can we afford it? Can we afford the upfront cost? None of these things are cheap. And then can we afford it going forward? If we make a decision to go with a platform and take the 12 to 18 months that it takes to move to that platform, we can't easily go change to a new one. That's another 12 to 18 months of commitment. That's having to write off the cost of the old platform and a massive impact to the financials. And, once you kind of say, yes, this is where we're going, you've bought in. And it's really hard to back out once you've gone down that road a little bit. But it also then flips over to the question, can we not afford to do it? So with large players like Optum, like Aetna, like Cigna that have national presence, like Centene, that can bring great scale and capability, we have to say, how do we best compete against them? And to compete against them, we have 2 factors. We have, well, really 3. Capability. What is it that we need to do to be competitive with them? We have cost. Can we bring that together? But we also have time. And time is probably the least understood of the factors. Because if we make a decision today that says, we need to be able to do this, it's probably 12 months before that's in, and probably 18 months before it's effective. So when we're thinking about things we want to be able to do, we're trying to predict the future. We're trying to look at 18 months out, 24 months out, and say, if we do something today, where does it need to land so that we're probably close to our competitors or ahead of them at the point where we'll have it in the market. And that's really the question of, can we not afford to do it? Because that the industry continues to evolve. Employer groups, states, CMS always expect more from us. The star ratings and the quality expectations and the risk scores we're measured against always keep going up. So there's always a question of, how do we do more? How do we get more effective? How do we create new capabilities? How do we implement something like AI? That's a huge conversation we were having in meetings this morning of just, AI is sitting there, what do we do with it? And so, that kind of leads into the third question of the capacity to make the change with our people. We can say we want to bring in AI, but do we all understand it? Do we have a leadership team that understands it, managers who understand it? And if we, put AI in the call center, for example, are we sure it's going to be telling our call center reps the truth? Is it going to be, always giving them the right answer? How do we test and validate that? How do we monitor it? How do we have confidence that it's a useful set of tools? Do we even understand how it works? All great questions. For Medicaid and Medicare and the ACA business, there's always the question of, does a regulatory body need to be involved? CMS or a state or the insurance department, or does a customer need to be involved? Because some of these very large commercial groups, organizations will have enough veto power over us, they can tell us things that they want or don't want. And so as we're making changes, we have to consult with our customers and keep them in the loop. the question of what happens if it fails and or is very delayed. You know, if we miss a window of opportunity for implementing, what's our backup plan and what's the cost of that backup plan? It's a huge question for us. As if we are aiming to implement, say, a new claims platform, and we have a date where that's targeted. If we continue on the old platform, there's cost for that, but we're still paying for the new platform. And we have all these new technologies that we're trying to implement, but paying for the old ones, and have to redo all of our transitions, communications, and everything else. And then probably the biggest thing on the risk side is, what don't we know? All of these things, we know about 85% of how they work. And then we discover a lot of things as we go along. We test, we validate, we find out things that the old system did that we didn't know. When we run comparison testing, we find all kinds of new things. And then we try to figure out how to fix that. And we have to plan that into our decisions about technology. Do we feel certain about our understanding of the platforms and the capabilities and what we will get out of it? And do we feel certain about the things that our old platform did, some of which may have been developed 25 years ago and written into code, and the people who did that retired, and they know what was there, but nobody else does. And we're learning some of that too. So that kind of then leads us to the reward side, you know, new opportunities, reduced operating costs, new market opportunities, when we learn something new. We look at new vendors that we have. Some of them we're just trying to see, is there something new or different that we'll learn out of it? And we do a lot of pilots and testing and ideas just to play with that and see what we get. Because sometimes we learn things that we had no idea were possible. And we have to create space for that to happen as part of our technology investment and our operational investment on top of that. And, you know, always the question is, our competition doing it too? If we see new services like over-the-counter benefit cards for Medicare or transportation services, we have to think about that all the time as well. We can't sit still and wait for, you know, our members to leave us because our competitors are doing new things and have new capabilities and we don't have them and they want them. So that kind of gives you the high level of how I kind of think about the problem. I'll stop sharing and we can have a little bit of a chat about it.
All right, thank you so much, Mike. And it was funny, you sounded like a CEO at the 80% of it, then you slipped into the 20% technical mind at the end, that was the old Mike. That was awesome. So thank you for that. Hey guys, everyone on the call, please raise your hand if you would like to ask Mike a question. I have one, as Mike was talking, I just keep on writing new questions and I'm up to 7 now. But I'll weave in my questions with yours. Your questions are more important than mine. Also, just a little pep talk. We is a community of people who want to make a difference for healthcare, and that includes you, hopefully. And so we want to get to know you. We want to collaborate. It's an awesome place to get to know each other, particularly at the conferences. It's a wonderful place to do it. But even on work group calls, see your face, talk, ask questions. We want to get to know you. So I want to encourage you to do that too. So Mike, I guess I'll lead it off. It was funny. I was out at a West Coast health plan and every conference room had a chair that was dedicated to their priority. And to be honest with you, I can't remember if it was a provider relations or if it was the member. I can't remember, but it was one of the two. And you mentioned, of course, scale. You talked about ratings, right? You know, those are things that are very important drivers to you. What other, you know, thinking about, you know, your members, thinking about your providers, thinking about your community, what are some of the, if I was going to go ahead and create a cost justification or a justification to doing a project, what sort of things would trigger you off to say, wow, that's pretty exciting?
So it comes to a lot of places. I mean, of course, there's always the base financial impact. Will it help us reduce our operating cost? Will it help us reduce our cost of care? Is there a way to deliver care more effectively at a better place in a lower cost structure? Will it help us drive revenue? And then you add in the other things of, does it make it easier for someone who's working with us, a member, a provider, a regulator, to work with us and get information or to be able to do something new that they couldn't do? Because that creates satisfaction, that creates stickiness, that creates a willingness to stay with us. And, you know, people who are already with you are a lot cheaper to acquire than the ones that you have to go back out and find or new ones. So you always want to keep those customers as well. For the Medicaid and Medicare businesses, one of the things we always miss is that the individual, while the state and the CMS create the contracts, the individual has the choice. And so we have to create a mechanism that makes them feel like we're really trying to support their needs and that they're finding the things that they're looking for from us. So that also kind of plays into that whole member experience side of creating an interesting desire to say this health plan is interested in helping me do what I need to do.
Good, good stuff. How about, you just inspired me to ask an eighth question. So what about health equity? Is there any kind of focus there yet?
There is, and I think it kind of depends on which part of the business we're talking about.
Okay.
So if you think about Medicaid, everyone who's on Medicaid qualifies under 139% of the federal poverty line. So say in Baltimore, that's about $42,000 a year for a family of four. So almost everyone with our group has health equity questions with Medicaid. With some parts of Medicare, very much the same thing. And Affordable Care Act, 90% of that group gets a subsidy to help them afford their health insurance. So when we look at health equity, we kind of always start with poverty and social determinants of health and the income needs that they have. But then that leads into things like food insecurity, housing insecurity, transportation challenges, childcare. And so all of those start to come into it. We're trying to capture more and more of that data and have useful assessments, but we're also very limited in some ways of what we can use federal and state dollars for to help with that. So we try to leverage the other parts of the organization that have a little bit more flexibility with either our foundation or other pieces to be able to have a positive impact there, where we can capture that data, that information. In Maryland, our health information exchange is capturing social determinants data and sending that back to us too. We have partners who are gathering that information and sending it to us. We're trying to create that, not just as somebody have diabetes and a particular condition, but also, do they have challenges with food or housing, or are they homeless? And we have mechanisms and data analysis that helps us identify people who are unhoused and where are they at a shelter. We can pick up an address there, or some of the other places that they may pick up an address. So all of that is stuff we're trying to gather. And then the real challenge then is, how do we fix it? Or how do we impact it? And that's where the real work comes of our folks in the field, taking that information and going out and talking to the person and seeing how we can help or connect them to resources that may be able to do something for them.
Yeah, awesome answer. That's great. There are people lining up to talk to you now. Val, you have the stage.
Thanks. I have a question. It is, you mentioned that you talk to the finance team a lot, and then you talk to everybody else. And can you really afford to do it? I was thinking when you said that, how can you not afford to do it? You need to do these innovative things. You need to find money in a budget. Do you think, or do you have some kind of innovative budget in your finance team to help with these new things? Because things are moving fast. And if you don't have a budget for it, like, do you not earmark it for next year and say, hey, let's put, 250,000 to start looking into things? Like, how do you do that? How do you talk to management about that?
No, absolutely, we do, or at least we try to. So one of the things we experienced, say, in the pandemic, we had money allocated aside for innovation and for changing platforms and everything else. And then a whole lot more people than we expected got ill. And so when I'm talking to the finance team, they're telling me, what are we seeing in terms of claims coming in? What are we seeing in terms of administrative costs? Say we have to hire nurses in a contingent way, and they cost a lot more than nurses might have 6 months ago because there's a pandemic and a lot of demand for them. And so we may set a budget at the beginning of the year, but then there's the month-to-month, week-to-week adjustments as we're seeing the reality start to flow in. So we may have money allocated away for investment and for innovation, but we also know we get a fixed amount per member per month of revenue. Say, if we get $1,000 a month for an individual from the state or from CMS or from the employer group, about 85% of that, $850, instantly goes to cost of care. So we know that's probably going right out, back out the door to pay for their health care, pay for providers, pay for home health, all those types of things. That gives us about $150 now per person. Probably about 88% of that, so about $80 now is for admin cost. So anywhere between 80 to $100 will probably is admin cost to pay for all the processing, all the staff who does the work, all the other components. So now we're left with probably $50 to $70 to do innovation, profit, change, new projects, all those types of things. And if everything's going to plan or we're having a really good year, it all goes well and we're putting that investment in. If it isn't going to plan, or we have a pandemic, or we have, a massive flu outbreak, and all of a sudden the cost of the care goes up to 95%, that money we thought we had for this kind of goes away. And now we're saying either we go into a deficit and we use some of our financial reserves to pay for that innovation, or we slow down the innovation because we've got to address the care, because we always have to pay the care cost first. And so we're always making those trade-offs, which is why I'm talking to the finance team every month, because it's a constant case of, are we good? We're good, great. We can keep going with these things. If not, we may need to slow down, adjust, tweak, look at different options. Sometimes we're into contracts and commitments that we just have to maintain. And so we have to go into a deficit sometimes for a year and just absorb it, take the hit. We have reserves and financial discipline around that. But that's kind of why I'm talking to the finance team so much, because every month it's assessing where are we and do we have the wherewithal to keep doing all the other things we want to do.
Mike, you sound like a CEO that time. that was really good. Hey, Val, thank you for the question. Brian,
Thank
you're
you.
next.
Thank you. Hi, Mike. Brian Dwyer with Point of Care Partners. My question is it might be specific to your Medicaid business, but it concerns the balance between investments on the clinical impacts versus administrative impacts.
Mm-hmm.
I've had some experience with this. And if you've got a potential investment that's going to have a potentially profound impact on the clinical side, do you then also have to, find savings on the admin side so you keep that, which is, I think in most states, a regulated balance of loss on each side? So in other words, if you were to cut your medical loss significantly with the risk of a ratio falling below a minimum, do you then have to find investments on the administrative side also?
That's a really good question, Brian. So one of the things in most Medicaid contracts that exist nationwide are things called risk corridors. And what a state will do is set it up to say, we're paying you the $1,000 per month. And, we expect that you're going to get a profit of about $20 of that per person. And so about 2%. And what they'll then say is, now we're going to put a risk corridor around that to protect your downside, but also to protect our downside. Mm-hmm. So if you have too much profit, we're going to take some back.
Right.
If you don't have enough profit, then we're going to, help you absorb some of the loss. So when we're looking at that, if we find really great opportunities to reduce the cost of care, we'll, of course, assess that. And then, we may be able to take some of that money and invest in other places to kind of get that ratio back up to the right place so that the state feels what we're in balance. But the state always views it as their money, and rightfully so. So if we make those investments, we also have to justify to them why that investment made sense. So we can't just say, well, we wanted to buy a new building because we saved so much on cost of care. They're not going to like that answer. But if we say, we hired 20 more people to go out into the field to help our members to have better experience, and we found new ways to impact the community, and we're working with the federally qualified health centers to do coat drives and book bag drives to assist the kids with what they need for the winter in school, they'll love that. And that's a good way to leverage those dollars. So it's always kind of the remembering that we're taking state and federal funds and we're trying to use them in the best way possible, but also trying to have the most impactful way we can for the members that we have.
Right. There's the mission always. Yeah. Thank you, Mike.
Yep. Always first.
All right. Thanks, Brian. I have a question, Mike. There's so much information about machine learning, natural language processing, people stating different use cases. Vendors are out there promoting different things. You start to see Google say things and Microsoft saying things, and other vendors are pushing out different use cases. I'm just wondering, based on some of your key drivers, have you heard of something exciting, something compelling that wants you to really investigate one of those newer technologies that would truly impact your organization?
Absolutely. There's probably several of them.
Okay.
The whole world of artificial intelligence and machine learning has been a big conversation. There was a recent study on some call centers showing that for the least experienced individuals in the call center, the AI helped them immensely and brought them up to the level of your much more experienced folks. So that's an area that's fantastic for us because call centers have massive turnover. It's tough to recruit, it's tough to maintain. Most call centers see between 80 and 100% turnover per year. So you get a lot of people who kind of cycle in and out, you're training them new. If there's a tool set you can help cut that time of training and development, absolutely, that's fantastic. Another thing is looking at care management for us and using natural language processing and using AI to go through all the medical records, go through the charts that come in from the doctors, go through the PDFs, go through the faxes. We still get faxes, sadly. All those things that come in and do all the parsing and processing and bring it up and say, yes, we've identified that this person does have diabetes and that they haven't seen a doctor in 1.5 years because we can't find anything that does that. So let's route that over to one of our care managers to give them a call, or one of our field teams to go out and find them, talk to their doctor and see if we can do something. But using all that processing, because we have massive amounts of data, what we don't always have is great information. And the information enables us to distill that data down into things that lead to action. Because we have care managers who have a group of 200, 300 people that they're supposed to be monitoring. And the only way for us to really make them effective is to be able to parse it down and say, here's your list of people you need to talk to today. Here's the things we think you should be paying attention to. The more we can help them with the easy stuff of assessing and coming up with ideas, the more they can spend time talking to the person and understanding how their health is and what we can do to help.
That's great. Speaking of care management, are you having difficulty receiving those clinical records to apply the NLP?
The technology is the least of the problems there.
Yeah.
Quite honestly. Getting the data in is straightforward. There's record standards, transaction standards, everything exists for that. It's getting the hospitals and the providers to, one, share the information with us. In some cases, if it deals with behavioral health, getting the individual to sign off and say we have an ability to see that. Behavioral health information has kind of another level of agreement in HIPAA as opposed to just standard physical health needs. So we have that too. Sometimes the providers just aren't interested in engaging in that conversation. So a lot of it for us is not technical so much as just operational and people questions. And the technology makes it quite easy once we can get that flowing.
Yeah, I would. The value-based care models, I would think it'd be a little easier to get the clinical data in a relationship with the provider. Is that true?
It is very much. What we've found is if they're engaged in that, we do get some good data, but there's still questions. One of the basic questions is around attribution. So we'll have a list of members that we think belong to the provider. The provider will have a list of members that they think they see, and those lists never match. And so, well, we may request data, they'll say, we don't know who this person is, and we won't get anything back. So there's always that negotiation back and forth to kind of get that aligned. The more we can do the data exchanges, the more frequently we can do them, the better that usually goes. But again, more of a people process problem than necessarily a technology problem.
Yeah, thank you, Mike. I got a lot more. You ready? We were at the summer forum, and it was CMS was leading a lot of discussions, and we had it was like an open open session where we were able to provide feedback to CMS, which was really kind of cool.
Mhm.
And one of the things they were focused on was the exception process. And they stated that the exception process was all about inspiring innovation. But when we asked the question, who's using the exception process, very, very few people actually raised their hands. And so the question that was something that arose within me is like, what's the balance? I mean, my gosh, how much effort are you putting towards that 15 cents or whatever, amount of money towards chasing down regulations versus truly doing innovation?
Oh, boy, that's a complicated question.
Yeah.
So
Payback, hey, payback from years past, just saying.
I appreciate it.
Yeah,
So with CMS, there's a lot of programs and interesting things we can do, but it also requires a lot of administrative structure to do it, and the value of scale. There's some value-based programs that CMS is running. There's some other components that we'd love to do, but we just don't have enough membership to make the investment pay off for us. And so, while it is that 15 cents per member per month, you've got to have 100,000 members in the Medicare program to make that, to generate enough dollars to pay somebody to do the work to figure it out. We have the same thing in Medicaid. There's a whole set of waiver programs that exist for the Medicaid programs where the state can ask CMS for things we can try around housing, around transportation and such. But it's a lengthy process. It takes a couple of years to get something approved. It takes some time to review it. There's a lot of back and forth. So while that may be there, it's a slow process to get it all done. So we may want to be innovative. Most of the time we're using our dollars from profit or using foundation dollars, or we're trying to find other ways to create some new ideas, and more often funding it out of revenue than anything else.
Yes, if I ask a question percentage-wise, percentage of that 15 cents of being applied towards of new development being applied towards regulations versus your own innovation, where would you put that at?
I'd say most of it's going towards regulations at this point.
Yeah.
It's a very complicated business, and rightfully so. I like to say that Medicaid and Medicare are probably some of the best health insurance someone could have, given the transparency, given the level of rigor that the states and CMS bring to it. But it requires a lot for us to keep up with it too.
Okay. Yeah, that's what I was suspecting. Thanks, Mike. I had to push it out of you. You said something earlier about platforms, not having one-off, or and then you have platforms that are really, making a lot of modifications. So it sounds like you would very much appreciate vendors providing these new AI, these new models inside of their new releases, as opposed to you developing them, that you can inherit them through development. So I'm just curious, you're right. Yeah. So what are you seeing from the vendors compared to what you want to do?
We're starting to see some of the vendors come out. I think some of the big players like Microsoft and Google are out in front of that. Some of the things we're seeing, quite honestly, are in Word and Outlook, and some of those areas we're seeing stuff happen very quickly. The platforms like the claims processing and care management platforms are starting to catch up, but it takes a while for those vendors to understand the tool set, make the contracts, get the arrangements together, start coding and testing and validating. So it just takes a while for those releases to work their way through the process. So with the things like ChatGPT and some of those components that have come out in the past 3 or 4 months, I expect by the end of the year, beginning of next year, we'll see those in the vendor releases. They'll be able to explain to us how they're going to work, what they're going to do. But it just takes a while for all that to work its way through the pipeline, because there's step by step of testing, validation, all those components. Now, when I used to push you guys for new things, we got them more quickly, but it was a different world then.
Oh, yeah. So speaking of that, this is a little pep talk to vendors. So I'm an old-fashioned software developer vendor from years past. And by the way, retiring on Tuesday. So I'll be completely independent and, but so something to kind of call out to vendors. I hope that the vendors could embrace some of the old ways. So when our word is our bond, so we go ahead and we make a promise, we make it where it's not too crazy for you to manage your own life, but you always keep your word and deliver full functionality. So it disappointed me when you said you didn't, you know, some of the vendors came up late and not short on functionality. I just hope that the vendor community here can serve you better in the future. And I know the vendors here will want to agree to that, I hope. So it's a little commercial for vendors. A competition, you talked a little bit there. And watching your competition, are you seeing any heavy technology innovation that is something that, man, you really want to jump on?
Oh, I'm seeing a lot. I think there's things that, like I said, Optum is doing some amazing things. They've got scale and data and understanding and process analysis that dwarfs many of us, and they're really playing. They're starting to play with AI technology. They're really starting to play with the ability to do some very complicated things at scale, some really quick analysis of data and medical conditions and next best action type activities that are quite impressive. Some of the smaller vendors are getting good at some innovation around that as well. But, I think the scale that Optum can bring to the problem is probably one of the best things that we've seen and is leading us to have a lot to pay attention to.
Okay, so how about on your competition? So to other health plans and adopting technology, are you seeing some things that feel a little like, man, I need to get on top of this because the competition's there?
Well, given that Optum is owned by United, that tends to make
okay. Well, we're not supposed to talk about vendors, and particularly since that's my company, I'm not going to say.
But I think it's for all of those. I mean, there's in Medicare, we've been seeing a lot of benefit changes and capabilities and being able to help people pay their benefits for their needs for utilities, their needs for groceries, be able to use benefit cards in retail stores and manage exactly what UPCs they can buy and not buy in real time. There's some very sophisticated capabilities we're starting to see with that, allowing us to offer new benefits that help people get the things they need for their health. We're seeing a lot from Lyft and Uber. In terms of being able to create transportation capabilities,
cool.
Even specialized transportation. They're starting to work towards that as they feel that's a competitive positioning for them as well. And we use them as fallback in transportation also. So I think some of those types of things we're starting to see. I'm very excited to see where the AI world is going. I think there's value there. The real question for me is going to be how to make it work with the data we have, and to keep it within our house so that it doesn't go looking for answers outside of the data and the data structures that we say it should.
Okay, thanks. I have a few more, but I'm going to lay out. I've grilled you enough today. Anyone else have questions for Mike? Don't be shy. Mike, you're awesome, man. That was a thank you for taking on all these hard questions, and your responses were awesome. So thank you so much, for coming to us and sharing your experiences, and hopefully it's been a valuable experience hearing Michael. So thank you again. You get a hand clap from Val.
Thank you, Val. I appreciate the time, everyone. This has been great.
Thanks very much.
All right, great. All right, thanks, guys.
Thank you. Okay.
See you guys.
Thanks,
Thank you.
that was really great.
Thanks,
Really
Mike.
great. Thank you.
Yeah.